Welcome, everybody, to this week's Power Hour. This week, we have an awesome group of guests in the panel, in the Zoom studio, as we like to call it. And we're going to be talking a very, very important subject with regards to end of life and palliative care. As a reminder, the Power Hour came about as a way to focus on conversation, collaboration, and above all, community in healthcare. So as a participant in the audience, you are welcome to unmute yourself and ask questions when there are any questions to be asked from the guests. And you can also put in your questions in the chat box, and we will make sure to get to those as the conversation progresses. My name is Christina Natterdog. I am here with Franklin Walker and my colleague Danielle Snyder. And you will also be able to find a recording of this session next week on the KIPL landing page and the North Carolina Medical Society website. Without any further ado, a huge thank you to today's guests for taking the time to be here with us and for sharing so generously with your time. And without any further ado, I'm going to hand it over to Franklin. Franklin?
Thanks, Tina, and welcome everybody. This is going to be a really, I think, a robust discussion today and very important to everybody. End of life and palliative care is a path that we all are going to have to travel at some point in our lives. Either ourselves, of course, or with some of our loved ones. And so we're excited to have some professionals in this area today on our panel. We know that medical treatment is very expensive in the last years of life. We know that there's a lot of research that goes into what's happening at the end of life. And we want to talk about all that today. But to get us started, I want to give each guest an opportunity to talk a little bit about their workplace and what their workplace is and a little bit of background on that. So Christine, I'd like to talk with you and give us a little background on Transitions LifeCare, please, ma'am.
Thank you so much. Thank you all for having me today. My practice is I'm a palliative care physician. I developed the inpatient palliative care consult service at the Wake Med Hospital Systems here in Raleigh. I started here in 2013 in that role. More recently, my role has evolved. I now am the VP of Education and Strategic Outreach at Transitions. So I'm working more in the community setting, and I still have my clinical practice, but not as heavy as I was just a few months ago. Transitions actually is a non-for-profit community organization. It started out primarily as Hospice of Wake County back in 1979. And the founding physician was Dr. Billy Dunlop, who's a currently practicing hematologist oncologist. At that time, he had that vision with 2 RNs. And actually the first patient under hospice was a child with leukemia. That was their first patient. And as the organization evolved, palliative care services started more in the community base back in the early 2000s. So at that time, Hospice of Wake was really ahead of the whole movement now of palliative care community based. And at that time too, Wake Med wanted to establish a consulting practice. Like I said, I came on in 2013 and Hospice of Wake became rebranded as Transitions LifeCare because really to better reflect what we offer and we serve. We do home health, palliative care, hospice. We do our pediatrics program, as you mentioned. We do surrounding 8 counties here, not just Wake anymore. So we're really expanding and we cover all these service lines. We have a large, robust staff. We have over 542 staff members, over 300 volunteers, over 7,000 families have been served from our organization. And like just our palliative care services, we've taken care of over 4,000 patients under our palliative care services. So really robust and really trying to be part of the community. From that too, again, I oversee the education department. We work the goal as an interprofessional teaching and training site. We have great collaboration with our Campbell Medical School, PA schools. We work with UNC Duke, and now more recently, NC State social work. So again, trying to really develop our interprofessional teaching and training, really mentor and partner again with our community. So that's kind of the overall view of Transitions LifeCare.
Super. Thanks, Christine. Rikki Hooper, I'd like to hear from you next, please, ma'am. Rikki is the Chief Clinical Officer at Four Seasons Care.
Yeah, so I am a nurse practitioner by background, and in my clinical practice, I've been the Chief Clinical Officer at Four Seasons for about a year now. Previously was a nurse practitioner and the director of the Palliative Care Program, so I've been here 17 and a half years in total. And I'm a recovering ICU nurse is the way I usually introduce myself. So Four Seasons is a not-for-profit hospice organization that has also been around for 40 plus years. We're located in Western North Carolina, so primarily in the Flat Rock area, which is a little south of Asheville, but we actually cover about 14 counties in Western North Carolina. So a good portion of our territory is very rural. We offer both palliative care and hospice services. We have an average daily census in our hospice of about 450 patients across the region. And our palliative care program currently serves over 1,800 patients across the same kind of area. So our community program is pretty robust. We have about 24 nurse practitioners or physician assistants primarily driving that program across the regions. And then we also provide service in several of the smaller community hospitals. So at Pardee, UNC in Henderson County, Advent Health Hospital in Henderson County, Harris and Swain, and then Highlands Cashers Hospital. So provide 7-day-a-week service out there. We see both pediatric patients and adults. But not as many pediatric patients as adults, obviously. Just really excited to be able to drive the palliative care movement forward. We've been doing palliative care since 2003 in the community and in the hospital. So, but still growing, definitely.
Super, thank you.
Welcome.
And then finally, Dr. Mike Nichols, who's with Coastal Carolina Oncology Center. Dr. Nichols, can you tell us a little bit about your operation?
Yes, hi, thanks for having me. I'm one of 7 doctors that practices at Coastal Carolina Radiation Oncology. Our group is all radiation oncologists, but of course we work closely with our medical oncology group here. And we also work closely with palliative care as well as hospice, and kind of serve the greater area around Wilmington, but including Brunswick County, Pender, Onslow, kind of outreach in those areas. And so palliative care is a big part of our practice. We have attempted, and well, I shouldn't say attempted, we have implemented a program with hospice that's kind of still somewhat being developed, where we try to do very rapid treatments where a hospice patient can kind of in one day get in, see us, get one treatment and get back out, back to the care center or wherever they may be, and kind of minimize their time with us and maximize time, you know, with family or at hospice.
Thank you, sir. Okay, next question I want to address, and I think this will be important to our audience. You guys have talked about hospice care and palliative care. Christine, can you define palliative care and hospice care for us?
Sure. Palliative care obviously is a specialty of medicine, and it really sees the person beyond their disease. And what is so unique about it, it's really a fundamental shift in healthcare delivery, because we're looking beyond just the person themselves. We are specialized medical care for people with serious illness. We're focused on providing relief of symptoms and stress of illness, focusing on quality of life for both the patient and their family. So I always say it's family-centered care. We base our care based on the needs of the patient. So, when people are continuing their curative, aggressive treatments for their serious illnesses, we provide support along the way. At any time of age, at any stage of a serious illness, we are there to help provide support along the curative treatment path. In regards to the hospice, obviously a lot of similarities. I mean, it's about quality of life and symptom management. So while the objective of both hospice and palliative care is pain and symptom relief, it's really the prognosis and goals of the patient that tends to be different. Hospice is more focused on more of a comfort care without that curative intent. Yes, you can go to your oncologist and get some treatments to palliate your symptoms, to improve your quality of life. But overall, the patient usually is no longer in the curative options. They are pursuing more treatments to palliate, to improve their symptoms, while understanding they're at a terminal stage of their disease process. So that's kind of how they're very similar, but yet a little bit different when we talk more the spectrum of care with hospice towards the end.
Sure. Thank you for that clarity.
Mm-hmm.
So people tend to live longer today than they did in prior generations due to the development of antibiotics, fluorinated drinking water, and other factors. But there's also, as you guys know, the social determinants of health, which seems to be what we're talking about so much today in our state and nationally. And I wanted to have a discussion around what you guys think, how important is the social determinants in terms of longevity, genetics, et cetera. And Rikki, I'll come back to you initially for that question, please.
Yeah, so, I think as we've made all these developments in treatment of specific conditions, we've got so many more disease modulating medications. We've got, certainly advances in the treatment of oncological conditions that has led to people living longer and people also seeking more curative / palliative interventions for a longer period of time. So even though somebody may have a stage 4 either oncology diagnosis or stage 4 COPD, advanced heart failure, they're getting so many more modalities that helps them live longer, but sometimes their symptoms are not well controlled. And so we're seeing more and more people staying in the palliative sector for a longer period of time before they transition to hospice. And that does unfortunately lead to shorter length of stays in hospice care. And, in other countries, the whole continuum is a little bit more fluid, if you will, because the insurance system is different. And so the payer system really drives the break between palliative care and hospice care for us in the United States. But certainly, I think we're seeing people stay in palliative care a year or two before they might transition to hospice, and then their hospice length of stay is weeks rather than the months that it really could or should be, when they can take advantage of all the other disciplines that are offered under the Medicare benefit.
Sure.
Rikki, I have to
go ahead, Mike.
if I can jump in. Sorry.
Please do. Yeah.
I mean, it's been a bit of an adjustment. I mean,
Mm-hmm.
to me, there were patients who we used to see, or I would see, who I would know that their life expectancy was maybe 3 to 6 months, and here they are now 2 years out, and it's an adjustment, and it's wonderful. But it's also, I find myself having more of a role because I treated them, let's say, for where their cancer had spread to their bone in one spot, and it's a good thing, but they continue to, I treat that, they get some pain relief, they keep on going, and another spot pops up and I treat that one and they keep on going. And so it's wonderful, but it definitely, I'd say a lot of this has come through the immunotherapy drugs, really has changed the landscape of how we're dealing with palliation.
Christine, did you want to jump in on that?
Sure, and I'm glad you asked this question. It's a great question to think about. And I think we all kind of, especially the last year, really had to kind of struggle with this. And one thing that I have learned is that, social determinants of health, really what that means is, it's both an unequal distribution of not only disease, but of well-being of our community. And so we have to really be humble and admit and acknowledge that a lot of what we call like biomedicine interpret the disparities instead of interpret it as someone's skin color as a risk factor. The reality is it's because of these social economic, these inequalities that has created. It's not so much the genetics. We have to be careful that we cannot identify that it's that's a risk factor. It is the social determinants that is a risk factor. And some of our colleagues now are really speaking out and describing racism. Really, we have to use the term racism to really say that's the risk factor, the social determinants of health, and focus more on the individual, the superficial aspects of the healthcare inequalities, and be very careful moving forward and teaching each other that and just learning about that. So thank you for that question. I think it's a great question. It's something we have to really be thoughtful about moving forward.
Yeah, for sure. And part of our coverage area is involves the Cherokee Tribal Reservation, and so working with the medication formularies that they have, working with the Cherokee Indian Hospital, the Indian Health Foundation. It does, not only are there other genetic tendencies within that population. There are also significant social determinants of health on the reservation that is different from outside. And then you've got the folks that are tribal, but they live off the reservation, and that creates a whole nother layer of challenge very often.
Well, I'm going to jump ahead because you guys have gotten us to a point that I think is important that we need to discuss. Langston Hughes said there's no color line in death. Okay. And I've given you guys some questions. The North Carolina Institute of Medicine released its report on serious illness in April of 2020. And one of the recommendations they put forward was to prioritize health equity and reduce disparities in treating serious illness, which is what you guys are kind of talking about. So I want to talk about how does this play out? Are minorities often left to fend for themselves, okay, in palliative care, and no palliative care, no hospice for those folks? And more importantly, what are each of your organizations doing now to address those disparities? So Mike, let me come back to you, please, sir.
Sure. I would say that what you're saying is absolutely true. I mean, a lot of, as Christine mentioned, and I agree with, a lot of what we're seeing is socioeconomics as opposed to race. But there are some race issues that I think that are important to recognize and be aware of because it helps you to bridge a gap. And that is that there have been historically things which were very wrong, experiments and such as that with syphilis, as well as taking cells, if you're familiar with Henrietta Lacks, taking her cells and using them without her permission. So there can be, not always, there can be some understandable distrust there in terms of what we're saying we want to do. And I think being aware of that and really trying to form that bond, and I will occasionally acknowledge that with my patients and say, tell me how you're feeling, which questions can I answer, and really opening yourself up and taking the time to have that discussion with the patient can be very helpful.
Christine, same question to you, please.
Yeah, thank you. I think the past year, obviously, we all worked in a really difficult time. And, I thought for the past years, my team and I, we recognize health disparity. When we're in the hospital setting, we would take care, for example, of a patient and their family and walk them through what it is to be uninsured, what it is to have lack of resources. And we always felt good that we could accomplish the goal of meeting not only their goals where they are, but also to get resources and to get support wherever they live. But last year really opened our eyes to recognize so much more beyond, because no longer was it one family or patient per week. We were now inundated daily, our whole census of uninsured, underinsured, newly uninsured, because a lot of millions of people lost their jobs. People forget that. So you were now trying to figure out, how do we do well for these patients and families, especially for families that lack the resources because there was a distrust. We never were proactive in engaging and building trust within some of our communities. And so it was such an eye-opening experience. I know me personally, it caused a lot of moral distress because we felt obligated. One of our metrics is the healthcare system looks at our reduction of hospitalizations, reducing hospital stays, reducing ER visits. But it's when you have a healthcare system full of patients with COVID and no resources, no longer could we bear that. No longer, it became more recognized this was an overall healthcare system issue. This was not a palliative care team. This was something so much bigger than us. And so with that said, I became more proactive, and we at Transitions started more cultural competency. We're really looking at cultural humility, because a lot of it is being quiet, understanding, having awareness of the differences that we can focus on. If we look at the origins of hospice and palliative care, it was white Europeans, right? If you think about the origins of our field of medicine. And so now we had to really think outside of that and really work more with our patients from minority communities and really be humble to that. And so I've developed a workshop. It's a 2-part workshop, learning about implicit bias, having awareness of that. Then how do I learn how to communicate? How do I teach more culturally competent conversations to lead to good care. And so that's what we're doing here. We're teaching. It's a long process, but we have to invest in each other to be better at how to have better conversations with our families and patients, meet them where they are, speak their language, not just linguistically, but, you know, I have patients that taught me, yes, I know my mom is dying, but we don't use that terminology. We say that differently. I need to know that because I need them to trust me to walk this walk with them, to lead them down the decision makings. And if I don't know that from the beginning, how they identify illness and how they speak about it and who's part of that conversation, a lot of our families are part of church communities that are part of these conversations. If we don't do that right and well from the beginning to establish that trust, we cannot walk this road with them down with this disease path. So we're doing initiatives, being very proactive about developing our internal professionals here, and then hoping to develop more and reach out to our stakeholders in the communities and offer these education programs for them as well. So that's kind of where we are with our development.
Super. I want to pause for just a second and actually welcome our fourth panelist, Dr. Lynn Bowlby with Duke Health. Lynn, welcome. Would you give us a brief background on what you do at Duke Health, please, ma'am? You're muted.
So sorry I was late. I'm the only physician in clinic right now, so, but I'm happy to be with you and thank you for the invitation. So yes, I'm a general internist at Duke. Duke obviously with many specialists, so I'm a little bit different. I was a physical therapist before medical school, and I run the resident clinic, creatively called the Doc, Duke Outpatient Clinic, where I have 70 medicine residents, so the biggest medicine resident clinic at Duke. About 15 other physicians, 2 APPs, about 5,000 patients, many of whom are underserved. So I function both seeing patients as a general internist, as well as the medical director.
Super. Well, while I have you, Lynn, I want to restate the question that we're working through right now with the rest of the panel and give you an opportunity to answer it. We're talking about addressing health equity and reducing disparities in treating serious illness, particularly in palliative care and hospice. And, you know, how does this play out? And more importantly, what are you all doing within your organization to address those things?
So that is, of course, a big issue for us as well. Our patients of color at our clinic are about 60% of the population, with a lot of social determinants of health in that, poverty and mental illness, substance abuse. So it is an issue near and dear to our heart. I was fortunate to do a year of some additional palliative training. So I am hopefully practicing not only primary care, general internal medicine, but primary palliative care. And I think for particularly our folks of color, where I could hear what Christine was saying, and I think we have many of those issues too, where folks use either different language, tough and different ways to talk about death, dying, and some of the symptoms that we want to help people with. And a lot of what we've done is try to incorporate into our regular medical visits and really try to hone in on continuity and allowing families to get to know their doctor, and then incorporating the palliative care principles and basic, treatment that all doctors should be able to do in palliative care. And a lot of our folks referring out does not work so well. We even did have a palliative care physician here for about 2 years who was awesome, who came once a week physically to our clinic, but it was still tough to get the patients to come in to see him. But we do certainly have a spread effect of palliative principles and teaching. And again, some of the more basic concepts, both from me and when your attending was here, he subsequently has moved up to Connecticut, so physically moved. But trying to really rethink all we're doing and be culturally aware who our patients are.
Super. Thank you. Rikki, I want to come to you next on that same question, please.
Yeah, so in the past year, we've really put some emphasis on the equity and diversity area. Because we cover such a diverse region, and sometimes the inequities are not necessarily skin color related. So some of our region, other than the reservation, of course, is part of Appalachia. And there's a specific type of culture in that region. Then, of course, the socioeconomics related to that are very different. So we have a, health equity, a HEDI initiative. We have a committee that has been working on some of those things. And then we also have a Project ECHO project where we have been bringing in some specialized education regarding health equity, implicit bias, some of those things that you were talking about, Christine. And so we've been able to take advantage of some of those platforms to be able to educate not only our staff, but other providers across the Carolinas as part of that ECHO initiative. We've had a speaker from Mississippi about implicit bias and about racial injustice. We've had a couple of other, a professor at Duke that came and spoke to us who actually used to work for us and is African-American herself. And she talked about her own experience walking through a journey with her father's care, with palliative care and hospice, and how that was, and some of the implicit bias that came to light during that she hadn't even noticed as a nurse looking from the outside in. So we've really been working on that. We have a couple of members of our board that we have specifically brought on as folks of a different ethnicity to be able to speak to the community focus. Henderson County especially has a large migrant worker population, so a Latino community, and there's a Latino advocacy center within our area that we're also working closely with and helping to educate our staff on how to care for that community in a different way. So I think it's been a process for sure, and we're just, we feel like we've just got the tip of the iceberg, and definitely some more work to do there. And then we have nurses actually learning Cherokee language, so that's kind of a fun thing to do out there.
That is neat, and it sounds like you guys have a very diverse clientele out there in Western North Carolina.
We do, for
really,
sure.
Yeah, amazing. I want to come back. Lynn said something about extra training that she had, and in run up to this session, I was reviewing Dr. Gawande's book, Being Mortal, which I'm sure you all are very familiar with given your line of work. And one of his quotes says, "I learned a lot of things in medical school, but mortality wasn't one of them." Okay, so my question, and I'm going to start with Mike, is given where you are now, looking back to medical school and some of your training in medical school and residency, based on what Dr. Gawande said, what would you recommend that you guys should learn in medical school that you didn't learn to do this kind of business?
Well, this may not be the answer you're looking for, but I went to Wake Forest Medical School, and I really felt like they did a good job. I mean, they did a lot of training in terms of death and dying, and we talked about it. And back then, I don't know what it's like now. I graduated in 2003, but you kind of started in the very first year. But we had, I forgot the name of what that course was called, and I'm sure all the medical schools have it these days, but it was basically around that kind of issue. And we would practice speaking with a mentor. It would be a pretend situation, but then we would go up onto the floors, and gradually they'd introduce you. First you'd watch, and then you would start to have these conversations. And I actually felt like it's helped me a lot. I see a lot of palliative care patients, as I'm sure we all do. And to me, the most important thing is communication with that patient, identifying what their goals are, and telling them what I can and cannot do for them. And that is often saying, I cannot extend your life with this treatment, but I can perhaps make your hip pain go away, or I can make your headaches go away, or I can make you stop coughing up blood, things of that nature. I saw a patient just yesterday who was referred to me that has quite a few metastases in their lung, and she's having a lot of trouble breathing. But at the end of that, we concluded that the best thing for her was for me to do nothing, and that's what we're going to do. maybe nothing's not a good term. I think I'm doing something by not doing anything and not always treating just because you are referred a patient. And so we agreed that she would be referred back to me if things change and she changes her mind and thinks I can help. And so I felt like my experience at Wake was very good training in that regard.
That's great. Glad to hear that. Lynn, since you provoked me to ask that question, perhaps you can answer this question.
Sure. And I have to admit, I love Atul Gawande, number one. I love almost everything he's written. Not that I'm a surgeon, but just I love his perspective. And medical school was frankly a few years ago. And I struggle. I was trying to remember as Mike was talking, did they actually say? Certainly the feeling in medical school is that death is the enemy always. And as opposed to a good death, or, you know, our culture isn't necessarily a culture that embraces the notion of death very well. It's not discussed often. I totally agree with Mike. You know, communication is just so much of the key to success. Connecting, being human, is so important. I've also been very fortunate to do Vital Talk training, which is one of the communication tools started by 3 palliative care physicians out west, Tony Bach and Bob Arnold and James Tolsky. This was at Duke, is now in Boston. So Duke is training many of us in Vital Talk techniques, and I had done it on and off for about 10 years now. But that's been a huge benefit, and to get to that heart of communication. So I think the more we as a culture can talk about death and that we feel okay talking about death with patients, it's just hugely important.
Super. Thank you for that perspective. Christine?
Yeah, I'd like to add to that in the sense, in my experience, and like I said earlier, we have every month we have 4th-year med students from Campbell. This is a required rotation, which I was really impressed years ago when Campbell approached me. So 4th years rotate every month on my service. And in my experience, they are thirsty for knowledge. They want to learn more how to be comfortable, not just speaking, but also how to recognize the dying process. So I literally walk them through, like I do any exam on my patients, whether it's an end stage terminal disease, what does it look like? How do we describe it to our patients? How do we normalize it? And I use the words a lot, actually, normal and natural. And so I hope to model when I'm seeing my patients that are end of life, because we take care of our hospice patients at the Wake Med hospitals. I walk them through that. I teach them, how do you care for a dying patient? What is normal and natural? And how do we describe it to our patients who are grieving at the bedside? How do I pull my interdisciplinary team, my spiritual care counselor, my social worker, my team to help do well for this patients and family? So in my experience, and not to pat ourselves on the back, but we're the most popular rotation because students really want this information. And then when they look back, they realize, wow, I took care of all these patients on my other rotations. We just didn't call it palliative care, but they really are all these patients with these end-stage diseases, whether it's neurology patient with a bad stroke or your end-stage COPD or heart failure. And so I always tell them, no matter what field you go into, pediatrics, you're going to have to be aware and knowledgeable about the end stages of that disease process, because they are looking at you, the physician, to navigate the conversation. They don't know what they don't know. It's our job to lead our families and patients with these conversations, and then also how to manage the symptoms when they're more at the advanced stages. So that's just been my experience, and I know the residents love it. I think it's just I just think it needs to be incorporated in general in our early training and medical education, and not just for med students, like the PAs. We have PAs now that are joining us, social workers. There's this really thirst for knowledge out there. So that would be my thought, is it should be part of the curriculum. So
super. Well, I'm glad to hear all these good things going on about the education of the medical school people right now. I want to switch gears for a second and go to Rikki and ask you, over the last year or so, we've been under a COVID pandemic. You know,
Mhm.
you guys have a huge footprint out there in Western North
do.
Carolina. Can you talk a little bit pre-COVID, COVID, and what you guys have had to change in your business model?
Sure.
Maybe some of the things that you've done to continue to be able to practice what you did practice in a safe environment, and how COVID has affected what you're doing. Thank you.
Yeah, so obviously we're a large enough organization that we see patients in all different settings. Our hospital palliative care providers had the benefit of accessing PPE that the hospitals had. As an outpatient, as a hospice provider, we didn't have like a huge stock of PPE because we just weren't using it. Our hospice inpatient unit did not have negative pressure rooms. And all of a sudden we were being asked to take COVID positive patients in our IPU. And that created some consternation amongst our staff. We have had to be pretty nimble and change things up frequently. The facilities that we partner with have changed the rules, sometimes on a daily basis, about who can come into the building, what equipment they have to have, what PPE they have to wear, whether that's going to be provided by the facility or whether we have to provide it ourselves. And so we developed a task force, our emergency task force or incident command committee, if you will, very quickly when the things changed in March in North Carolina, where we're kind of watching other areas and knowing that things were going to creep towards us. And because it's such a large area, the rates of transmission have been very different in Buncombe County and Henderson County or Clay and Graham, and you could almost see things moving across the North Carolina dashboard. So we had to pull in telehealth pretty quickly in order to be able to keep our staff safe. We have been using a platform, kind of more of a messaging platform, the TapCloud platform that we could use out in the western and the more rural regions. And so we were already using that, and we had to switch gears and be able to utilize that for video visits very quickly. And so we were able to employ that. We also had been using that within our hospice team out there through a grant previously. And so that didn't take us much time to kind of get into gear, if you will. We figured out how to do virtual admission visits for hospice. We went from doing 100% in-person visits to doing 75% virtual visits, both in palliative care and in hospice. We did do some virtual visits even within the hospital. Our hospital providers went from seeing 10 patients or having 10 patients on their caseload list to, at one point, I think we had a total of 45 patients between two hospitals in Henderson County. The Christmas New Year period was pretty crazy. I covered the New Year's weekend, and we had 13 new consults on top of our 36 existing patients just in one day. So that just required people to shift and be flexible. It also required us to think outside the box, to be prepared to do things that we hadn't done before, to be resilient, to communicate better, and to support each other in a different way. We had to find space and time in our day to be able to connect with one another through Zoom platforms, kind of doing a daily resilience huddle, if you will. We developed kind of staff calls, and at the very height of things, we're having daily staff calls where staff could call in and ask the leadership team questions about, what do I do if I don't have enough masks, or where do I go to get a new N95, or what are we doing about this, or what are we doing about this facility that now won't let our social work and chaplains in? What do we do about our patients? And developing new partnerships with those facilities. And then also just having, routine meetings that we are still having frequently, not as frequently as we have, but, we're still, as an oversight team within our environment of care committee, still meeting every week, talking about how do we change things up this week? What's going on across the state? Which color are our counties? What do we do about providing N95 or KN95s that, and then the whole, the N95s that were counterfeit that we kind of had to deal with. We created 4 negative pressure rooms within our hospice IPU. And we had to message the community that we could take these patients, but we were sealing that off from the rest of the facility because we had not only staff that were concerned about it, but also community members who did not want to contract coronavirus coming in to see their loved ones. We also had to make some tough decisions about visitor restrictions, which is always, goes against the grain when you're having folks fly in your hospice IPU. And that didn't feel good to a lot of people.
I would think that would be one of the most difficult things. Thank you for all that. Mike, I want to come to you next. You're in a little bit different setting. Of course, you're down there in the coast. How did COVID affect your business model in dealing with your patients?
A lot of similarities to what Rikki had mentioned, I think probably for all of us, but radiation oncology is a little bit different because we have our daily clinic where we see our follow-ups and consults just like anyone else. But then we also have 3 linear accelerators that treat the patients. And so every single day, over 100 people, aside from our follow-ups and consults, are coming in and out to get their radiation treatments. So that's a whole lot of traffic going in and out of one place in one day, and not knowing necessarily, the practices of these people each day in terms of their risk and exposure to COVID. And so we, from a consult and follow-up standpoint, started to do a lot more Zooming. In radiation oncology, we also do a lot of tumor boards where we meet with other oncologists, and often palliative care is there, and other supporting doctors and other services. But we went to much more Zoom. We're only now actually starting to get back in person, but of course we limited visitors. Both patients and physicians and all staff had to wear a mask covering their nose. Whereas patients on treatment used to come into the building and go to the waiting room after checking in and sit. They would now get there, wait in their car, tell us that they were there. Then we would call them and say, okay, the machine's kind of yours. They would come in, we would treat them, and then they would leave. And, when we still were unsure about contact precautions that were needed, we were wiping everything down. And we were very diligent. None of our physicians or physician assistants had COVID, which we were quite proud of. There was some within our staff, and of course they were then quarantined as appropriate and out. But it was quite an ordeal, and I agree, we had to support each other, and it was at times stressful just dealing with this uncertainty. And what do you do when you need to go in and put a scope down a head and neck cancer patient's nose? This was pre-vaccination, knowing that you may make them cough very hard right in your face. And, and of course we wore the personal protective gear, but there's always that uncertainty that's not perfect either. And so we took all the measures we could, and to our knowledge did not have any exposure within our clinic. Of course, that's impossible to know with certainty, but none that we're aware of.
Right. I want to follow up, Mike, something you just said about pre-vaccine. We're clearly in a vaccine stage now. Vaccine's been available since around December for most of these folks. You guys are physicians and healthcare providers, more so for the patients. How did you, Mike, how do you all evaluate one of your patients' eligibility for a vaccine? Do you recommend it? When do you recommend it? What's your decision matrix?
Well, I recommend the vaccine to anyone who's age appropriate. Of course, we don't see pediatrics, and so I don't we have to deal with that issue too often. But in terms of adults, I recommend it with the exception of patients who have been undergoing chemotherapy, and then I will defer, or immunotherapy, I will defer to the medical oncologist in terms of their recommendation. But unless their counts are just extremely small, in which cases they sometimes won't apparently generate antibodies. I believe most of those patients were also recommended to have it.
Right. Okay. Thank you. Christine, I want to come to you next and talk a little bit about the differences in adult patients versus peds patients. In a run up to this thing, you and I talked briefly about when you guys at Transitions brought on your peds, business model. So can you talk a little bit about that, please?
Yeah, thank you. Our PEACE program started about 5 years now, and it's all philanthropic support. I'm sure a lot of you all know it's very difficult in this field in regards to pediatrics, especially getting that payer support to do this right and well. And by that, I mean, again, just like palliative care for adult, it's an interdisciplinary team approach, but even more in depth in regards to how much support is done in the home setting. Our program now, we have about, we have about 80 something children under our care model. Their average child stays on our service about 1.9 years. But our team now is about, I believe we're up to like 12 pediatric hospice palliative care team members. It's all home based. So our team does, and they've been using telemedicine even prior to COVID. So again, trying to think outside the box, how do we expand our reach to service areas that, once the children were seen at Duke or UNC and they no longer could be on a more curative path, or they were in disease states that families just wanted to remain at home. This is where we fill that gap, is that we support these families and patients back in their home setting. The difference too is it's not uncommon that if a child is in distress for symptoms and the family does not want to go back to the hospital, we have our pediatric nurse specialists there 24/7, sometimes for crisis management. And so it's very different in the sense that you don't always get that in regards to the adult side, especially palliative care. We don't do that in adult palliative care. We can't have a provider there 24/7 if someone's in distress from their symptoms. But the children's program is a lot different. They do more of that. They're more in the family home more often, and it's a longer relationship. It's not uncommon if a child does go back to the hospital system. We have a relationship with Duke, UNC, WakeMed. It's not uncommon that one of our team members, our PEDS team member, will go in and see the patient and just regroup with the team there, with the family, because they're that trusting continuity of care there. And so we've established that. So again, that could be different than what we see necessarily in the adult world. But again, similar goals, right? Trying to do more supportive services, focusing quality of life, reducing physical and emotional pain and distress. So that's that common link there. It's just more in depth and can be provided more for the children's as opposed to the adults. So that's kind of what ours looks like.
And I suspect you encompass more support for the parents as well.
Absolutely. Yeah. And also we have for siblings, we have programs. We have, again, our pediatric specialists that will engage more. Obviously, sometimes like I've done home visits where we're just there with the siblings. The patient themselves doing okay and fine and stable, but we're there actually for the day for the sibling support and for the family and just kind of processing that.
Right. Thank you for that. Mm-hmm. Okay, Lynn, I'm coming to you, and I want to talk a little bit about workforce, since you had mentioned that I think you have 70 internist residents that you're working with, and I think it's widely agreed that there are not enough palliative care physicians and hospice providers. And I'd like to talk about what might be strategies for increasing the inflow of folks into those particular areas, and then also what might be the strategies for expanding primary palliative care to ensure as many North Carolinians have access as possible. So it's kind of a twofold question there, please.
Yes, and thank you. So most of our 70 residents are going into specialties in internal medicine, endocrine, cardiology, GI, et cetera. And right, not enough palliative care physicians in the field. So certainly at Duke, they are exposed to palliative care fellowship. So that's 1 or 2, maybe a year. And they certainly apply to other palliative care programs, but I think there's only 300 palliative care physicians boarded every year. So a lot of the energy is, again, trying to teach the principles of palliative care to everybody. Medical students and then residents, sometimes using the words palliative care, sometimes not, and reinforcing that whole notion of what all physicians should feel comfortable doing, and that we don't need to refer out to palliative care for every patient with serious illness, every patient with who is dying. What can we do first and keep the patient under our roof? And often we have those relationships, so that's part of the role, obviously, of a primary care physician. So I think the workforce is using a lot of the people that we have and just giving them additional skills, which I think medical schools and residencies are looking at. Duke is essentially training all medicine residents as well as others in, for example, Vital Talk, the communication skills, which is all about serious illness and care and end of life discussions, and giving people tools to use for that. So I think that spread has really helped.
Okay, super. Rikki, I want to ask you a derivative of that question. Again, thinking about the geographic spread of your operation, the longevity of your operation, and in 2020, 2021, what are your strategies for expanding, your care? And also, how difficult is it for you to recruit and retain palliative care physicians and workers?
So that's a great question. So, our program is highly advanced practice provider based. So we, as I said, we have about 24 advanced practice providers, mostly nurse practitioners. Each of our areas is, broken down into smaller teams. So we've got a hospital team, we have a Western community team, North community team, South community team. Each of those is led by an advanced practice provider. We do have physicians, but we have a physician. So it's basically like a 1:6, 1:7 ratio. We utilize our physicians in the hospital. We utilize them in our cancer care clinic, and also in our community clinics, where we tend to have a younger, more complex population. So a lot of our APPs are going to skilled facilities, assisted living facilities, and then home visits also. As I said, we're using telehealth a fair amount of the time, probably down to about 20% of our visits are now telehealth. We also have social work and nursing as part of our team. So when I first started in palliative care, it was all just provider. And we had kind of like a token social worker who would help with resources. Now we're much more into counseling. We are seeing a lot more younger patients with more complex psychosocial issues, with substance abuse disorder overlaying their other serious illness, and trying to navigate around resources for those individuals. So we use our nurse to triage things. We use the nurses to do initial clinical assessment. So they do a telephonic assessment when we get a referral. It's not been too challenging to recruit nurse practitioners, and not even as many physicians. We've had a palliative care fellowship in Asheville that we've been a part of for a while. And so we've been able to actually, more than 50% of our hospice physicians actually went through that palliative care hospice fellowship. So that's been very helpful for us as an organization. We, several years ago, did have more trouble recruiting nurse practitioners, especially. And so what we started doing was taking new grads. So we'll take a new graduate nurse practitioners and train them in the way that we want to train them. And we developed a transition to practice program in the last 5 years, I would say, that's been very successful in being able to retain those individuals longer term. And they're usually local nurses that have gone to graduate school and then want to stay in the area and don't really want to do primary care. And there's not as many opportunities for acute care either. So, but that's kind of been our workforce multiplier, is being able to utilize advanced practice providers. I think in the future, we are going to need to use more nurses and more social work within a serious illness model. And then also looking at the home-based primary care to overlay the palliative care programs too.
Super. I mean, it sounds like you guys have a very comprehensive strategy.
We do.
Christine, I want to come back to you and tell us about the importance of family engagement and faith, or lack thereof, in your business, please.
Faith as in a religion or spirituality faith?
Yes, yes, ma'am.
That's a great question. Can I ask why you asked that?
Well, as you know, I think I talked to you about, I've been out there a few times when Dr. Dunlap gave me a tour years and years ago. And I noted some things there that I've kind of tucked away. I have been through the transition with my father several years ago, and found that family engagement at various and sundry levels and faith at some point was important.
And you're absolutely right, for everybody. And it's just defining what is faith, what is
Sure.
having a spirituality for each of us. What does that mean? And so again, starting from the beginning of engaging with my patients and their families and learning about how they define that, how do they follow that spiritual faith, or what is their religion or religiosity of that nature. Often in my experience, there's usually a support person or caregiver or family that, even if my patients tell me, I don't tell my family this, or ultimately what happens is there's a lot of family and patients that want to protect each other. And so I learned that all these years that my patient may be saying one thing, the family saying another thing, and often it's the same thing, but no one's talking to each other. So once you kind of establish that trust of how that patient uses their religion or their spirituality to lead them and guide them through these difficult times, and then how to put that missing piece for them, whether it's a caregiver. Some people, they use their community as their family. Again, it's identifying who is their support person or peoples, who is their people, and putting that all together and navigating that. And so for the most part, in my experience, a lot of people, especially when we're starting to face our mortality, start exploring it more. I have people that they want to start talking again about what they used to believe in and navigating that, or they used to be a practicing Catholic and now they want to engage in that again, or whatever it is. It's just identifying that. And again, I'm lucky I have social worker, just like Rikki says, we all work with social workers and spiritual care counselors that help us piece that all together and really get that detailed information. But I like that question. That was a good question, being thoughtful about that.
Well, and I appreciate you wanting clarity. It can be a difficult question for a lot of folks, I'm sure. We're getting close to the top of the hour, so I want to give you guys one more question. It'll be the same question for each of you. Mike, I'm going to come to you first. And if there would be one or two things that you would love to see happen in your work, whether it was a piece of technology, a piece of legislation, or some silver bullet, if there is such a thing, that you'd like to see happen, what would it be?
Well, that's fairly easy, but it's a big general answer. That would be just better access to care for everyone, so it's not so expensive. And, as I'm sure we all do, I have patients. I'm dealing with one right now. I mean, he literally cannot afford to drive to get his radiation. And if he gets his radiation, I could probably cure his cancer. And if he can't, then he will die from his cancer. And so, it's heartbreaking to see. And, you want to reach out and just like say, I'll pay for your cab or whatever. But of course, that's not reasonable and you can't do that. And so that's what I would most like to see.
Thank you. That's a great answer. Lynn, how about you?
Yeah, so I'd have to say similar, working with an underserved crowd, not to be so specific, but expanding Medicaid or providing insurance for everyone in this, it's horrible in this country. And it's so complicated, even if you have insurance, because the rules are all different for every different payer, the amount of time and energy staff spends on that when we could spend it with patients.
Mm-hmm.
So that would be my dream, more insurance and less complicated.
I agree with that one. Rikki, how about you?
So I have a wish list. A functional EMR for community-based palliative care.
Oh yeah, I'll vote for that too.
Okay, yeah.
a different payment structure
Mhm.
so that our non-billing disciplines actually got paid for what they do. So social work and nursing. And you know, as Mike and Lynn have both said, the ability for all of our patients to get what they need to get when they need to get it is an appropriate insurance system, that we don't have to spend 2 hours trying to get prior authorization for medications or fill in 10 pages of paperwork for a wheelchair or something like that.
Right.
Yep.
And finally, Christine.
It sounds like I have the same wish list as everybody else. This is our dream world. It's like you all said, is really more a value-based environment. We can no longer worry about payer source. We all should be able to offer the same fair, just care, regardless of who I am seeing in my office or at the bedside in the hospital setting. It should not matter where my patient lives. It should not matter the barriers. We should be able to have, it's really about equity of care across all our patients and population. So that would be our dream, is to have that environment so that everyone gets that equal access to care.
Super. Well, we're at the top of the hour, and I want to say in closing, one, thank you to my panelists. You guys have been superb. You've been one of the more realistic groups that we've spoken with over the last 18 months, which I think is just awesome. Your dreams are realistic. The North Carolina Medical Society shares a lot of those. We continue to work on those. And this is such an important topic that we've discussed today. So I want to thank you guys a lot. We'll see you guys on the next Power Hour in about 2 weeks. Everybody have a great weekend and take care. Thank you.